Good evening, good morning, good afternoon, depending on where you are in the world. Thank you all for joining me on this webinar. I'd like to thank Viva Learning for making this possible. My name is Heidi Dubois. I am a dental hygienist, and I am currently employed by Integrated Dental Systems. So thank you again. Tonight's topic is the etiology of problems around implants. We know that there are lots of things that go right about implants, but tonight we're going to focus on some of the complications that may arise. We are going to look at implant maintenance and specifically talk using Air Clean, which is a single unit dose glycine delivery method. Some facts about implants we want to look at. We see that the implant market has grown exponentially and is going to continue to grow based on need. What's happening now in the industry is many of our patients are more educated than members of the team that you currently work with. So I'm going to encourage you to take some of the information you gather this evening and take it back to your offices so everybody is on the same page. The last thing we want to do is have patients come in knowing more about treatment than we actually do. As the number of implants goes up, several things can happen, allowing for more issues. We used to say that implants had a 99% success rate. That success rate has gone down now to somewhere between 90 and 95. When we look at the rates, we factor in several things. More implants are being placed by non-specialists. In fact, this year was the first year, 2017, that more general dentists placed implants than specialists. The next thing we want to look at when we look at that is the lack of follow-up. Many times the patient has an implant placed and restored and does not realize they need to go back and have maintenance done on their implants. In fact, in my career, many times patients would come in with overdentures, with locators, and never took their overdenture off. So as we go through forming a protocol, we want to make sure we give our patients things in writing. We're noticing now the trend 3 to 7 years out, patients are starting to develop infections and diseases around their implants. 64% of all implants are going to form some sort of mucositis. 18% of those are into peri-implantitis, and it is not a guarantee that those implants are going to fail. There are many things we can do to help treat those areas. When we look at those diseases, they are marked by a bacterial infection that surrounds the supporting tissues of an implant. The difference between peri-implantitis and peri-mucositis is determined by bone loss. So the goal is to try to get you to identify these areas of mucositis before they have a chance to get this far involved. This is definitely a problem, and we want to identify these issues before they advance. With the amount of plants that are being placed by a variety of different people, who does this fall upon? Well, if we look at the U.S. Department of Labor statistics, we see the number of periodontists compared to dental hygienists that are out there. It's very difficult for the periodontist to treat all of these problems, especially if they become peri-implantitis. So with the hygienists out there, we really want to focus on how you can maintain and identify early issues so we don't have a big problem. This is truly disciplinary treatment. Dental implants are not just place an implant and send the patient off. We all have to be involved in the long-term success of this. Hopefully that success rate will continue to stay around there and not go further down. It can be very confusing. As a hygienist, many of you have fear bases. You're not really sure what you're looking at, fear of the unknown. There's no protocol. Sometimes you know more in the office than the rest of the people in the office, including possibly your boss that you work for, depending on how involved in implants they are. So how are we going to form these methods of taking care of people that come in? In order to do that, we're going to take a step back in time and we're going to just go over anatomy. For some of you, if you're like me, it's been a long time since we've gone through this. Let's look at just the basic anatomy of an implant. We're going to go crown down because that's really the way that you see it in your practices. So you have a crown, then you have an abutment, and an implant which is integrated into the bone and the gum tissue. It looks, feels, and functions just like a natural tooth. I would imagine that there are times when you can't even tell just by looking in somebody's mouth clinically whether there is an implant in place or not. So these are things that can be somewhat challenging to us. Let's look at a little bit further. We're going to strip the gum back and look to see, comparing a natural tooth and an implant. What anatomy is there in common between the two? So if you could see, there's epithelial lining everywhere, the oral epithelial, the sulcular epithelium, and the junctional epithelium. Where it gets different is, to keep things simple, a dental implant does not have a periodontal ligament. That is the main difference when you're looking at the two side by side. When we look at the natural tooth and we look at the ways to the tissue, there are Sharpie's fibers. So the fibers are going to go perpendicular and all the way around the tooth surface, attaching in. There's a blood supply going there. There's connective tissue that is actually attached to growing into the surface of the root. When you look at a dental implant, there's no perpendicular fibers. It's junctional epithelial seal only. It's a little almost O-ring, if you will, that's around the area where the attachment is to the implant surface. And I'm going to, right here, you can see where they're pointing. This is the difference of the gum fiber tissues. And as you can see right here, there is no attachment from the bone into the implant. So what is the peri-implant sulcus made of, and what is its main purpose? We look at peri-implantitis. It really acts as a barrier in the oral cavity. Not getting fluid and things running down in from the sulcus down in there. It's lined by clavicular epithelium, and its tissue tension is like a circle, as I said, a peri-mucous seal. It looks like an O-ring almost, if you picture it, an O-ring around the implant. It's very difficult when you start periodontal probing around implants. You don't want to get in there and probe really hard so that you're poking through that seal. It's there for a reason, and we want to make sure that when we start talking about that, we're aware back of the anatomy, which is why I wanted to start with the anatomy in the first place. Let's talk about truly survival and implant success. Do they mean the same thing? You could look at this radiograph and you could actually see that the implant is integrated into the bone, so it's surviving. It's probably not loose. It doesn't have disease, but it's certainly not restorable. So survival of an implant does not always mean success. And when we look at what makes an implant successful and what makes it not successful, there's several factors in there. So survival means it's not mobile and it's still in the patient's mouth. Success means restorable, it's pleasing, the patient's happy, the clinician's happy, there's absence of probing or depth more than 5 to 7 millimeters around it with bleeding, no bleeding, there is no recurrent pain or abscesses, all the symptoms cleaned off, you have a stable radiographic view every time you take your periodic radiographs, there's no bone loss, and the patient's comfortable. That's truly what we want to see, that the patient is comfortable in the bite and the dentition with the functioning implant. So that leads us to why they do fail. What makes an implant fail? Long-term overall health status of the patient is very important. Smokers, success rate of smokers and implants goes down dramatically, especially in the beginning when the implant is first placed in that integration phase. Surgical and restorative skill is very important to success and how long that implant is going to stay in the mouth. More importantly, now we're going to focus on implant maintenance. Hygienists not recognizing early issues, or whoever is performing preventative maintenance on the implant patient. Overuse of cement and occlusion. So first, I'd like to encourage all of you to get a really good baseline. Anytime you have a patient that is coming in to possibly have implant treatment, really take the time to get a good overall picture of what that patient looks like. We want a full health history. That includes any systemic diseases that they may have, good clinical exam, including tissue evaluation. This is where I encourage people to use intraoral cameras if they have them. Some people actually just take pictures with their cell phones so they see what the color of the tissue looks like in the patient's mouth. We're going to check for mobility, whatever your radiograph's capability is in the practice that you're in. Obviously, if you have a CBTC scan, it's much easier things on that, but set a protocol up with bite wings or PAs, how often you're going to take them once the implant is placed. Full mouth probing, really important. As we start getting into the breakdown of disease, patients that have periodontal disease are more likely to have peri-implantitis. Again, that goes back to the home care and what we're teaching them in how often we see them. Occlusal exams and study models, especially if that patient is going to go into night guards. So just setting that office protocol in place prior to treatment is really, really important. When and if an implant does fail, there's two phases of implant dentistry we're going to take a look at, the surgical phase and the prosthetic phase. If an implant fails in the surgical phase, it's usually going to fail within the first 6 to 8 weeks of placement, and that's usually involved with systemic conditions, autoimmune, that's immunocompromised, smoking. If you're doing single stage surgery and you're putting a higher healing abutment on, if there's any rubbing, their tongue, removable, anything that can cause trauma onto the implant can cause failure in the surgical phase. Once the implant is restored, there are several other reasons why the implant may fail. First and foremost, I have to touch on this, who's making your prosthetic parts. With CAD/CAM dentistry, it's really easy now. Most of the implant manufacturers, warranties are null and void if you're not using the same parts. If an abutment does not fit properly into an implant, there's going to be micro movement. Micro move on the implant can lead to implant failure, very similar to a fence post. Over torquing and under torquing are just as difficult and problematic to an implant. Every manufacturer has a certain spec of Newton centimeters that screw should be tightened into, that abutment should be onto that implant. It's real important that you're using the right drivers and the right ratchets to make sure that happens. Occlusion, remember, an implant is not a tooth, it doesn't move, and it does not have a periodontal ligament. Therefore, if the teeth shift, the implant does not. Even the slightest high occlusion can cause a problem around that implant. And excess cement. Right now, I believe a study was done out of Northwestern University. They came up with a statistic that 80% of all cemented crowns around implants have cement somewhere subgingivally in the circumference of the implant. And a lot of the times we don't see that on radiographs because it's not evident on the buccal or the facial. You can't really see that. So in the surgical phase, again, proper planning and location is really important. Bone sets the zone in where the implant is going to go. We want to make sure we avoid angulation issues. As I've before, just because an implant is integrated does not mean it's successful. So proper placement is crucial for the success. And you can imagine this lab is going to have to do some serious maneuverability to even see if those implants can be restored. So we want to make sure that the implants go in the right place. In the prosthetics, this is where you see a lot of people missing this mucositis diagnosis. Getting in there and seeing just a slight inflammation around the implant is really important to catching it before it doesn't become implantitis. Again, we talked about the non-OEM parts. Excess cement, it's really interesting now to see the trend going back to screw-retained restorations because of the problems that people are having with cement, ex-cement. Over and under torquing, again, I can't stress enough, use the manufacturer's torque. Hand torquing is not sufficient on an abutment for long-term success. And occlusion, really important to check the bite routinely. When you look at the restorative plan is going to be and how that implant is going to look, you look at the upper picture and you may think that's a beautiful case, but is the design amenable to patients keeping it clean? When we look below, and it may be a little hard to see in this picture, but you could see that there is bone loss around the anterior portion of that full roundhouse case. And having to say to this patient, just because it looks good doesn't mean it is good. So we want to be sure that we make the right capability for patients to keep those things clean. Whoop, I hit one too far. So again, the restorative responsibility is to fabricate crowns with the right contours so the patient can keep them clean. This is your chance, the minute that implant is restored, to take a probe basis, a data, get your data on your probing. What is the probing around that implant done? So you can have a baseline of what you're going to look for. What is your recall schedule that you're going to maintain? Are you going to send this patient back and forth to a periodontist? So establish these guidelines in the practice so everybody's on the same page. Removing all subgingival cements, again, if you're starting to screw retain your restorations, this is not as much of a problem. So we've looked at the overall status, hygiene status, surgical and restorative skills, cement, we're going to get into a little more. Now let's look at implant maintenance and a hygienist or a dentist not recognizing issues early enough. So what is the recare? My personal opinion is the first year until you establish how that patient is going to respond to taking care of the implant, especially if it's multiple teeth. Get them on a 3 or 4 month recare right away, but again, get them where they're comfortable. Radiographs, carding, oral hygiene instructions, scaling. We're going to talk about scaling around an implant. You should remember they are going to build up calculus, cement, and debris, so you want to make sure you keep it clean, and then air clean, which is the unit dose glycine. When we come in with recare appointments, for those of you that have treated long-term patients that start getting a little recession possibly around the implant where you actually could see some of the metal, it's more obvious to see where this biofilm is building up. But what I want you to take a look at in this picture is the color and the tone of the tissue. Let's just pretend the tissue was all the way up and you did not have threads exposed. That tissue is still going to look red and angry in the area. That's a direct indication that something is going on around the implant. The biofilm is really what's causing the majority of the problem right now, and that's where the research is. We want to make sure we get the biofilm off. Well, anywhere in the oral cavity for that matter. Natural teeth, it's the same as it is on implants. Today we're going to specifically relate it to implants. So biofilm removal is crucial. And what is a biofilm? I get that question asked. A biofilm is an organized colony of bacteria or plaque that gets seed and forms a polymer matrix in a simple term that sticks to the tooth. So what they're finding to be very successful in recommending is air polishing to actually remove the biofilm so you can keep the area clean. As far as an implant goes, the more you biofilm off the surface of the implant, the better chance you have of that implant staying healthy. Removing that biofilm is crucial for the health around the implant, both preventatively and for treatment-wise. When we look at an implant, there's a healthy implant versus an unhealthy implant. When you can treat something preventatively and get it so if there's a little film forming and you could remove that, the statistics show that the breakdown is going to stop. So we're going to really look at how we remove biofilm and control what's happening in the oral environment around the implant. When we look at the bacteria that causes peri-implantitis, they're finding that it's the same bacteria in periodontal disease in teeth as it is in implants. By the same token, the bacteria that's in healthy teeth is around healthy implants. So the microflora is really, really important in the patient's mouth, what is going on in disease and what is going on in health. Again, here, I want you to take a peek at the tissue tone. Dental implants will build up plaque, biofilm, calculus, and many times even stain, just like natural teeth do. But here I want you to notice the biofilm on these healing caps. Look at the tissue tone. Look at the color of things. I'm going to take this a step further and look at the upper denture and the plaque that's around the upper denture. These are warning signs that this patient is not compliant. What are you going to do when this patient comes in? For me, I'm going to hand that patient a hand mirror and show them where the bacteria is, where the plaque is, and take them to the next step of what they're going to do to keep it clean. I don't know that those implants should even be restored right now the way they look. I'm not a dentist. I'm not a periodontist. I am a hygienist. It looks like angry tissue to me. So, again, we have to sometimes pull back and determine what's going to be best for the patient. So all this talk about monitoring, how and what do we monitor when we look at dental implants? There's 4 things that are crucially important. Bleeding on probing, color of the tissue, exudate or suppuration pus around palpation, can't even speak this evening, or occlusion, excuse me. So those are the things that we're going to look at, and this is going to determine if it's starting to get in trouble. Is there disease around the implant? Is it starting to break down? Early signs that these things are happening are really important. The next topic can be very controversial, to probe or not to probe. Literature indicates, you can always find somebody that's going to argue this with you, but probing upon implants is crucial for gathering a baseline, if nothing more. Just because you probe around an implant and there's a 5-millimeter pocket does not mean that's a diseased implant. Implants tend to be buried deep. Remember, when you're probing around teeth, you're probing and you're getting resistance from the connective tissue of that periodontal ligament. We don't have that in an implant. A lot of times, you're going to take that probe deep enough around a tooth that it can sink in. If an implant is placed at bone level, they're creating a larger, so to speak, or sulcus, if you will, and that's going to give you more depth. It's crucial when I'm going to go back a slide, when you're probing around an implant, unlike a tooth where you're going to feel that resistance, the probe is going to go attached closer to the implant and the abutment where it goes. And this is really important, and in fact, I want everybody to emphasize this, and I will say this a couple times. Just because when you probe on an implant and there's bleeding, that does not necessarily mean there's disease. However, you probe an implant and there's no bleeding, there is not disease. Healthy implants do not bleed. Even if you're probing 5-6 millimeters, that implant is not diseased if there's no bleeding there. Bleeding on probing around an implant, it may just be very early onset of peri-implant mucositis. That's treatable, especially when we start looking at air clean and glycine. That's something that you can control and treat and reverse right away when that patient's hygiene improves and we do the right things. This chart is just a helpful chart to show you when and where and how, and I have an expression I use all the time. When in doubt, refer it out. If that is something that you feel is out of your realm of treatment, the periodontal community is there. Many times what happens is we are inheriting cases. We may not have placed the implant, we may not have restored the implant, but that implant walks in off the street from somebody else, and now this is your new patient with a full set of dentition other than maybe 1 or 2 spaces that have an implant. You've inherited that patient. You've adopted that now into your care. So a lot of these things, you are cleaning up somebody else's mess, so to speak. You want to be aware of that. When we look at healthy peri-implant mucosa, it shouldn't bleed. It should be nice and healthy looking. The color is really important. Get a little bit of local irritant there, a little bit of biofilm building up. You start seeing a little bit of breakdown, completely treatable, versus letting it go when bone loss is involved. And that's the biggest difference between mucositis and implantitis. So clinical mucositis, a little bit of bleeding on probing, maybe increased baseline depth. Sometimes that doesn't always indicate maybe you aren't probing any deeper. But if you're bleeding, there's a little bit of something going on. It doesn't mean it's advanced yet. And no progressive bone loss at all. Mucositis will not have bone loss. Please feel free to type in any questions. I am going to take time at the end of the presentation to review questions. All of these slides are going to be available in this webinar, going to be on demand, so you'll be able to get back to those charts if you need them. And again, those are just guidelines that you can follow. Some of those things change a little bit. We don't have air clean added in that chart, so the person that's asking for that, you will definitely get that. Now let's look at peri-implantitis. You could obviously see this is progressive bone loss. Usually the pocket will grow around the tooth. You're going to see it's going to go everywhere, all the way around the circumference of the tooth. There will be bleeding on probing. There usually will be pus or some sort of exudate coming from the area, and it may or may not have mobility. Many times an implant can be integrated and still have peri-implantitis. Sometimes it's just one side, it's a one-wall defect, and that implant is still somewhat integrated. So that's not always an indication that there's a problem. Again, this is another chart just to kind of help you. This was done, and again, there's probably some newer charts that are out there. This one I find very helpful. And again, for the practice that I was in, this is when you start paying attention to things. Now with Glycine and Air Clean available, anybody that comes in that has an implant is going to get treated with Glycine around the implant to prevent this and remove the biofilm that we know is there. I don't want to see anything go moderate. I want to keep it in the early moderate stages, no advanced peri-implantitis on my watch. So we really developed that protocol. If you have plastic scalers in your drawer, this is a public service announcement. Throw them in the garbage. They don't do anything. You need to get some titanium scalers. There's lots of other types of scalers that are available. I'm boldly going to say to you, if there is cement or calculus subgingival on an implant, I'd rather you use a regular scaler and get it off than leave it there. So I'm not going to talk about which manufacturer to use. There are a lot of different options out there for scalers. These are titanium scalers. They make piezo scalers with Cavitron scalers for implants, and there's thoughts on that as well, but make sure you get yourself some good implant scalers. Air polishing is very much on the uprise right now. People know that it's effective. We've used it in dentistry since the 70s. Prophy jets have been around for a very long time. We now know that removing the biofilm around an implant and breaking up that microbial floral really will help prevent progression of the disease. So again, as we said before, the microbial flora is similar, healthy teeth, healthy implants. Air polishing systems that are out there now, there's a lot of big, bulky systems in the market. They're all very effective. Some of them have different powders you can put in. Some of the issues that they have are clogging of the lines. They're bulky, they're cumbersome. If there's multiple hygienists in an office, they only have 1 or 2 units on a mobile cart that goes back and forth. And if we are now recommending we monitor and identify early onset of these inflammatory response, we should be using Glycine on all of our implant patients. There is a tremendous amount of research done on air polishing and Glycine. I encourage you to get out there and look up Glycine. There are hundreds of articles and studies that have been done. Glycine powder in an air polisher around an implant or even around natural teeth is very effective. The beauty of Glycine, it's an amino acid. It's an essential protein building block that's resorbed in the body. It is very, very, very soft. It almost feels like baby powder. The micron size is that of baby powder. Very gentle on the tissue. And the big thing is it's been shown to decrease P. gingivalis, which is one of the leading bacteria in periodontal disease that is in a biofilm. So because it's proven to disrupt the biofilm, and it doesn't, we're advocating it around implants, the microns are so small it does not scratch the surface of the implant. Keep in mind that all implants that are going in place today have a roughened surface to speed up osseointegration, but the Glycine will not alter the titanium surface. So if you're using it subgingivally, which because of the tip, air clean tip, you're going to be able to get this in very difficult to reach areas. You're almost going to see a reduction of bleeding right away as you're using this. It's very comfortable and easy to use on the patient. I actually was sampling this at the Amos meeting in Chicago, and I had somebody spray it in their mouth because they wanted to see if it had a taste. It's very sweet. It's not offensive to the patient. Here are some of the abstracts. As I said, if you type in glycine in Google, you're going to get a whole lot. It's been studied for a very, very long time, and we're not going to get into all the weeds of what that is. You can do that on your own time if you're so inclined to do that. So air clean is the method, the delivery method, and the difference between some of the larger air polishing units and air clean is this is something that's very easy. It's an air polishing system that you can use in your operatory on any of your hand pieces. The tip is very malleable. You can use it in hard accesses, areas that are hard to access. You can use this subgingivally along the surface of the implant. The powder is so low, it does not work with water. It's controlled, the air pressure is controlled. I'm going to go back. You can put it on any of your high or low speed hand pieces because inside the adapter, it's going to monitor the amount of pressure. It comes in unit doses like this. What we will do is your first purchase is an adapter and 10 unit doses. That adapter fits on, as I said, any of your hand pieces, and the unit doses that comes 10 in your first box. So what you're going to do, showing the adapter, I'm going to turn back on. This is the adapter. This is the unit dose of glycine. The adapter goes on your hand piece. The unit dose is going to slip right in. You're going to pull out metal tip just enough so you're going to be able to release the powder that is going to come out. This is what it looks like. It easily connects to any of the 4 hole hand pieces you have. This is a water-free application. That's very important because as you're going around the implant, and I'm going to go into how you're going to position this, water is not coming out, and many times you don't want to take anything with high pressure or water and go into the sulcus with it. That's not what we're recommending doing, and that in fact can cause several problems. So we're going to be very careful of how we are going in. I'm going to show you it clinically working. I've got a little video that's going to play. I will talk you through this. So the hand put in, it's in place, nice and tight. You're going to hold the metal nozzle between 1 and 4 millimeters to the tooth surface at an angle of 30 to 90 degrees. Spray each side of the tooth for a maximum of 5 seconds per tooth. Don't concentrate the spray in any one place. You're going to use it like a brush motion. I'm actually going to show the video again. So the adapter goes. Each unit is good for 3 to 5 teeth. And again, we're talking about implants, but this can be used anywhere in the mouth. So you see how it's being used as a brush. Difficult to tell in this. I know it's not, the clarity is not that great, but you're going to continually move that around at a 30 to 90 degree angle to the tooth. There's no water coming out. You can rinse if you want. The beauty of Glycine, it's absorbed by the body. So the benefits of air use. So it's really easy. You have one adapter and it can bounce around the office very quickly. You may only have 1 or 2 implants in an area. And if you have a large piece of equipment sitting in your operatory with sodium bicarbonate in it, you don't want to go ahead and mix it and drop it out and clean a line. You don't want to ever take any of the things that are in a ProfiJet and directly put it on an implant because it will alter the surface of the titanium. That's what makes this so special because it doesn't change the titanium, doesn't alter the surface of the titanium. Single unit dosage, and it definitely is the most effective way to treat mucositis. with the quickest, best delivery system, something that can be done in every single referral. Used on recare patients and at the time of placement. As you saw on that one slide where there's healing caps, a lot of people have bacteria patients come back in and you're doing single stage surgery and you're uncovering the implant. Why not? If it's going to prevent biofilm from building up, use it. Especially, before you maybe take an impression or seat a case, you can use it at any time. That was a question that just came in, so thank you. This is how it comes. As I said, you get a hand vector and 10 units. That's your starter kit, and then it comes in 30 units in a box. Here's some testimonials. We were lucky enough to have some hygienists really raving about the product, and one of the things that I liked the best that this particular Natalina had said, it's definitely a go-to for implant care. And she was explaining to me when I spoke with her that you could actually see the debris coming out of the surface. And somebody's asking, can you go subgingival with the metal tip? Absolutely. Again, it's designed to do that because it's low pressure. There's no water, and you're going to keep it at a 30 or 90 degree to the implant surface. Here's another testimonial, and I think for me, where we look at that recare treatment, let's say you have somebody that comes in and they have a little bit of inflammation, maybe some minor bleeding around an area around an implant, go ahead and hit them with the Glycine, the air clean, and then I would bring that patient back in 6 weeks and check it again. You can retreat. There's no time frame as to when and how long, how often you use this. And it is something that if caught early, like I said, you can actually reverse the problems of it. So in everyone's practices, there are patients that have implants that have slight mucositis. So how good would it be to take care of these people, get them in more often? And if you look, I'm going to put my cursor back. Obviously, you could see the tissue tone there. There's a little bit of the exudate right there. Taking that air clean in an area like this, and again, why not use it on the natural tooth? This is where we want to get with it. And we want to make you see this patient was probably aggressively flossing, knowing they were coming in to have some dental treatment done. They wanted to show you that they are taking good care of it. Somebody's asking, has this been used with ortho patients? Yes. Glycine has been tested in the mouth everywhere. It's a very effective way at removing biofilm. How you use the glycine is what we're talking about tonight in that single unit dose. So please feel free to add any more questions around air clean. Go ahead. We're going to take some time at the end and answer them. I do want to talk about cement and occlusion on failure. Cement is a very problematic issue right now. And again, you may have all figured this out, how to use cement around an implant. You may have made a protocol in your office that you're not cementing implants anymore. You've watched how you've done it. Somebody's taught you how to do this. You're not over cementing. You've gone to screw retain. But remember, you have inherited a lot of patients that didn't start with you. So you are taking care of somebody else's problem. If you look closely here, you could see there's a little bit of change in the tissue tone. This patient came in, several recare appointments. We were watching them closely, and finally we decided to do something about it because we realized something was going on. When you apply cement now, you want to make sure that it doesn't spread more than 1 millimeter under the sulcular area. There are several great ways to do that. Lining a crown with cement. You don't fill a crown with cement like you would on a natural tooth. Very fine line, and there are a lot of different techniques out there. My favorite is taking the crown. If you have a lab analog or an abutment analog, go ahead and put your cement in, put the crown on the analog, take it off, the excess cement will stay there, and then you put it in. Another method people are using, they'll actually take the crown and they'll fill it with impression material and put a back end of a Q-tip into that while it hardens. Once it gets hard, you take it out and you have an exact duplicate of the inside of the crown. Put a little cement on your crown, stick it on that duplicate, the replica that you made, and then put it in the patient's mouth. But again, there's lots of different cements out there that peel off. Implant is one of them, and you can use that and it peels off relatively easily. But again, you want to watch the amount of cement you're using. So let's watch how this panned out. Here you have bone loss, cement. There's all sorts of issues going on with this patient here, and it's definitely a problem. What we now know is we can clean this, get rid of the biofilm, remove the cement, clean, sterilize, re-sterilize the surface of the implant, and have great success with that implant not failing, not coming out. This is a radiograph of cement. We're not always lucky to see it. I had in one lecture, somebody recommended using zinc phosphate because you could see it subgingivally better. But clearly, just by looking at the bone loss around this implant, you could see there's a problem. The x-ray on your left shows a baseline x-ray. That was after the implant was placed, before it was restored. Now you see the different where the bone loss is. That's a problem. You got to go in there and clean it out. Some people would bone graft and let it heal. Some people would just leave it like that, because you could see there is a tremendous amount of implant that's still embedded in the bone. This implant's probably not loose. Clinical exam is everything, though. You got to check all aspects of it. So here's back at that patient that's probing with the implant, with the cement. We probe the area and get a small little flap was made in the area there, right here. The cement was removed. That's a rather large piece of cement. It was on the direct facial, 8 millimeters subgingival. That's not going to show on a radiograph. Many times that's not going to show when you're probing around an implant or scaling around an implant to on a regular maintenance. You're not looking for those things because it's on the direct facial and you're kind of afraid. So this shows us how looking at the tissue tone is really important. So we saw what the color looked like. Next, they took a piezo scaler with, here you could see the implant tip on that. They scaled completely clean on that, debrided the inflammation in the granular tissue that was there, so they got healthy pocket. Our air clean was used, rinsed off, a little bit of a bone graft was placed, and the patient was good to go. And follow up on this patient, I can tell you that the implant is still in place. This was done 4 years ago. It's my mother. So I always thought I was a really good hygienist, but I wasn't checking 9 millimeters subgingival on the direct facial of an implant. I would now, but that implant is still in place. We were able to save it. So again, early diagnosis and recognition of what's going on is really the problem. Tissue color and consistency, as I said, is what we're really looking at. You can actually take 2 fingers on either side of an implant and squeeze tissue and see if exudate's going to come out. That's another really good way to tell. Sometimes when the patient bites down, if the occlusion is high, you're going to see something come out of the pocket. One of the hygienists that actually was using air clean mentioned to me that she was able to see that the debris and the bacteria come out as she used the air clean in the area. Occlusion, I always recommend every recare appointment have a piece of articulating paper out. Remember, teeth move, implants don't. And as teeth move and shift, the implant stays attached to the bone. So a health implant will not be mobile. If your implant is mobile, you got a big problem. One of the things that people will ask me about often is fractured screws. 99% of the time, a screw is fracturing because it wasn't torqued appropriately, the abutment was not seated, or the occlusion is high. So you get a pretty good indication if you're using factory manufactured parts and the abutment was seated properly and your screw breaks, there's a problem there. And again, implants can stay intact that are only 25% integrated, as I showed you in that last slide with the cement. That implant is still in there. You're not going to take an implant out that's still integrated. We recommend shim stock to evaluate the occlusion. Once the articulating paper is high, you can go ahead and do this. And there's lots of different courses. If you are involved in implant dentistry, I highly recommend you take an occlusal course. There are so many factors that can change quickly with occlusion that would cause implant failure. And again, this is that's an FYI. That's a public service, another public service announcement. Checking for mobility in an implant, again, just use your fingers. You're going to see if it rocks. You could do it at the same time by taking a perial probe in a mirror like you would a natural tooth. Sometimes you're not going to catch the movement. You'll be able to feel it. A lot of times the patient will come in telling you their implant is loose. You have to determine whether it's the crown, the abutment, or actually the fixture itself. So a lot of people have asked in the course of us launching this AirClean product on implant reimbursement. I feel that it's an office decision on if you're going to charge for AirClean or you're not. I am providing you insurance codes. I am not guaranteeing you that there is going to be coverage, but these are the codes that the ADA has come up with, the insurance codes that are used for implant maintenance, implant debridement, flap clean, when you have to flap an implant, and these are the codes that are being used. Again, I am not up to speed on whether or not, and I would not guarantee one way or the other whether there's going to, but using that single unit dose AirClean is something that is relatively easy, and you can contact your local distributor for more details about the AirClean, what it's priced at, and catching those problems early is really, really important. AirClean is distributed by IDS Megagen. You can call or email for more details. You're going to get that information from me in the next slide. So again, you must probe around implants to start a baseline data. That I want you to really watch the pressure that you're putting, just get an idea if there's bleeding around there, if there's exudate coming out. Peri-implant bone loss starts on the labial. That's usually the first place you're going to see some of it start happening. Radiographic changes can often aren't there until late in the disease. So you have an ability to catch these things and treat these things before they become a real big problem. So I want to thank you. I'm going to take some questions in a moment. My name again is Heidi Dubois. I am a hygienist. I am with IDS Megagen. You can get a hold of me at heidi.dubois@idsimplants.com. That is Megagen's number. AirClean is being sold through your local distributors. I am really appreciative of all of you for tuning in with me this evening or this morning or this afternoon, wherever it may be. I am going to take some Q&A right now. You can get, so one of the questions is what distributors right now? Patterson, Banco, Nashville, Atlanta, more, and please feel free to call and reach out. We will get that to you, the information to you. Name of cement that is easy to remove is Implant, and you could get more information on that as well. AirClean can be used for stain on natural teeth. I wouldn't recommend it. It's not as strong as the ProfiJet. Remember, the air pressure is purposefully not coming out as high. The micron size of the particles are too small. Are there any contraindications? No. It's a naturally occurring amino acid. So it's natural in the body. You're going to rinse it off after. Are the AirClean units also being used as a microabrasion unit? You can use it with different, the Glycine is not. You can use it with different products to go into the tip of that. Can AirClean be used on natural teeth? Yes, it can. Can you remove cement with a cap? Again, you can. There's some controversy in cavitrons, and that we could do a whole other webinar on that. Just getting the cement off is really, really important. A question was just asked, can AirClean be used on implants? AirClean is a product to be used on implants. It is to prevent peri-implantitis and treat peri-mucositis. Is it advisable to use on brackets and ortho? I don't see why not. Again, it's a biofilm removal. I am going to go through these in a moment. There's so many questions here. I just want to make sure that everybody knows this is going to be a demand, and you can get these slides on demand. AirClean system used in place of power polishing or as an adjunct to scaling, both. You do not want to use prophy paste around an implant. It can scratch the surface of the titanium. You don't want to use a prophy jet with any of the powders in it other than glycine around an implant. Again, it's all about keeping the implant, not scratching the implant. Not use air clean with water. Ask an air clean be used with water for stain. You cannot use air because of the adapter. The adapter is meant to block out water and meant to control the air pressure so that you don't cause a problem when you go subgingivally. This tip is specifically designed to go around the implant subgingivally to keep it clean as long as you're keeping it at a 30 to 90 degree angle. Can you use implant? Can you use it on the day of implant? Yes. To prevent, as a preventative measure, absolutely. Can we go subgingival with the metal tip? And if so, what will, okay, we already asked, will it scratch the titanium? No. Somebody's asking about the insurance code. Again, this is on demand. So you're going to see that there is that slide that showed all of the different insurance codes. There is one there that you could apply to use of air clean. Question, can you use this method around crown fit chronic tissue also? You can use glycine is safe to use anywhere in the oral cavity. You can treat any type of biofilm with this. It is specifically designed to remove biofilm. So again, I encourage you to take your education in your own hands and take this to the next level and look up glycine and start researching some of the things. There are no contraindications for glycine. It's naturally occurring in your body and in many of the things that you put in your body. So it's a naturally occurring amino acid. I think there's a lot of repeat questions here. So I am going to so it's using the actual prophy paste. Yes, you do not want to use prophy paste around an implant, especially if you're using a coarse prophy paste if the patient has stain. It will, if there's any of the exposed threads, it's not good. It's not good for the implant surface. You want to use something that's not going to. Is it contraindicated to use a Cavitron on an implant? That's a controversial question. There's a lot of different philosophies and thought processes on that right now. I'm going to defer to. I'm going to not answer that question on this particular webinar. Can you bone graft immediately following air clean procedure? Rinse it off and you can bone graft. Do you recommend it's used at each recare visit when the rest of the natural dentition is polished? 100% absolutely. We have looked at the statistics. 64% of all implants have peri-implant mucositis. So why wouldn't you use it? That's the question. I ask that, in my lunch and learns all the time when people say to me, should I be using this on every implant? It's a preventative measure, and it's much easier to use a little unit dose of glycine to prevent a slight amount of mucositis from becoming a problem. So I highly recommend that this is something you incorporate into the protocol that you're doing. How many minutes will it be hard? It does not get hard. It doesn't harden at all. The glycine isn't going to turn into a hard substance. You are going to spray it around and you're going to rinse it off if you even want to. So you're not using water with it. You can give a rinse afterwards. The patient can rinse their mouth afterwards. Again, it's absorbed by the body. So I want to thank all of you this evening for, somebody is asking the cost of the kit. It is $400 for the adapter and 10 carpioles, 10 units. That's the starter kit. And then the replacement tips come 32 a box, and those sell for $90. So reach out to your distributors. Feel free to contact me. I'm always available to take questions, and we are happy to, somebody's just asking, this is a great question. Any association with stomach upset? None at all. Again, this is a naturally occurring amino acid in the body. So you're not going to get any stomach upset. You're not directly spraying it. You want to use a high-speed suction, high-speed suction when you use it. You want to have safety glasses on. Probably you're going to put safety glasses on your patient, and you're going to be sucking most of the excess that's coming off out in a spray. You're going to suck that away. So I appreciate it, everybody. Have a great evening, and we are going to close it out.